Welcome back to Decode Healthcare with Harshal. Today, we are celebrating a massive milestone because we are officially entering Chapter 2 of the ICD-10 CM guidelines, Neoplasms. Let's dive right into this explainer because coding for cancer, well, it's not just about matching words to numbers. It's really about telling the exact legally binding clinical story of a patient's battle, their treatment, and their recovery. So you got to ask yourself this high-stakes question. When exactly does a deadly, life-altering cancer transition from an active, critical condition into just a simple history code on a patient's chart? Getting this wrong doesn't just create a minor typo, it creates a massive compliance error. So our mission today is crystal clear. We're going to master Section IC2 of the CMS official guidelines, lock down the absolute foundation of cancer coding, and understand exactly how the reason for an encounter dictates your principal diagnosis to help you avoid those huge compliance errors. Okay, here is our roadmap for this explainer. 1. Foundation of neoplasm coding. 2. Sequencing, follow the treatment. 3. The active versus history boundary. And 4. DRG and compliance impacts. All right, jumping into Section 1, Foundation of Neoplasm Coding and the absolute authority of CMS guidelines. Now, this direct quote acts as the absolute constitution of medical coding. Textbooks are great for learning, for sure, but when it comes to inpatient and outpatient coding, these guidelines override absolutely everything. The text literally states, the instructions and conventions of the classification take precedence over guidelines. Only this set of guidelines approved by the cooperating parties is official. So you must rely entirely on this document as the supreme law of the land. Moving right along to Section 2, sequencing, follow the treatment, and looking at primary versus secondary malignancies. To sequence correctly, you've got to anchor yourself to this definition. The principal diagnosis is the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. Put simply, the primary reason the patient walked through those hospital doors today dictates everything that follows on the claim. The core difference here is pretty straightforward. The primary site is the original ground zero where the malignant tumor grew, while the secondary site is where the cancer has metastasized or spread. Think of the physician's treatment like a clinical spotlight. Your sequencing depends entirely on where that spotlight is shining during today's specific encounter. If the patient is admitted solely for treatment of the primary malignancy, that primary site gets the spotlight and is sequenced first. But what if the cancer has spread? Let's look at a real clinical scenario to see how this plays out. Imagine a patient has primary lung cancer, but unfortunately, it's metastasized to the brain. Today, they're admitted explicitly for a craniotomy to remove that brain tumor. So where is the clinical spotlight? It's right on the brain. Following the CMS guideline for the treatment of a secondary site, when an encounter is directed toward the metastatic site only, that metastatic site is designated as the principal diagnosis. So step 1, you sequence the secondary brain malignancy first. Then step 2, you sequence the primary lung malignancy second, even though that primary cancer is still very much present. The absolutely crucial point here is this. The principal code always equals the focus of today's treatment. In our scenario, because the surgical spotlight locks onto the brain, that metastatic code moves into slot number 1 on the claim sheet, and the lung code just snaps right into slot number 2. Okay, Section 3, the active versus history boundary. Chapters C00 through D49 versus Z85. Listen, there is a strict, unyielding boundary here, and this is where so many compliance errors happen. Over on the left, we've got active malignancies, chapters C00 to D49. An active code can only be used if the tumor is still physically present or if the patient is currently undergoing active adjunctive therapy. Even if a surgeon cut a tumor out years ago, if that patient is still receiving maintenance chemotherapy or radiation directed to that site, the malignancy is coded as if it still exists. It remains active. But look at the right side. If the tumor has been completely excised or eradicated, there's no further active therapy, and the scans show absolutely zero evidence of remaining disease, you have officially crossed the boundary. And the guidelines do not leave this open to interpretation. As this exact CMS directive states, once those criteria are met, eradicated, no further treatment, no evidence of disease, you are strictly forbidden from using an active cancer code. You absolutely must use a personal history of malignant neoplasm code from category Z85. This isn't a suggestion. It's a rigid legal standard. No active disease or treatment? Switch to a Z code. I want you to visualize a digital gauge swinging from an active red zone right into a safe green Z85 zone. Once treatment stops and the scans are clean, you hit a hard stop on using active codes. You must retire that active code immediately and swap over to the historical Z85 code. Which brings us to Section 4, DRG and compliance impacts, the high stakes of coding errors. Now, in the outpatient setting, CPT codes are often the money codes that drive revenue. But in the inpatient setting, it's all about the MSDRG, or Medical Severity Diagnosis Related Group. And what drives the MSDRG formula? You guessed it, the principal diagnosis we just spent all this time breaking down. If you missequence a primary and a secondary site, or if you accidentally leave an active cancer code on a claim for a patient who is completely in remission, the cascading effects are huge. You inaccurately shift the facility's clinical data, which triggers an incorrect MSDRG assignment. That leads to immediate financial line item flags from payers who are definitely going to spot the discrepancy. Ultimately, it creates severe audit vulnerabilities for your hospital. Placing an active code where a Z85 history code belongs is going to set off immediate alarms. Think of a giant flashing warning saying Auditor Alert, validate active malignancy criteria. Missequencing these primary and secondary sites completely alters the DRG, putting a massive target right on your facility's back. We've covered a ton of ground today, but the rules of Chapter 2 only get more intricate from here. Before you go, make sure to hit that subscribe button, leave a like, and drop your coding questions down in the comments. Now, I want to leave you with this provocative question to chew on. How do you sequence a patient admitted strictly for chemotherapy-induced anemia? The answer involves entirely different sequencing laws, and that is exactly what we're going to tackle next time in Part 36 as we master the strict rules for coding complications of cancer treatment. Until then, keep decoding.